Thank you, everyone. It's not a secret about what happened with the New York Times, and since then, the endovascular revascularization has gone down significantly. I want to tell you all, it is really your obligation and your responsibility to actually re-educate yourself and do endovascular revascularization, because without it, really, limb salvage has gone significantly down. The data today showed significantly increased in amputation since the New York Times article came out. And it's okay to talk about it. And I'm here to show you that what my colleague said earlier, if you need, this is my disclosure, if you need any help, just don't hesitate to ask someone to help you. And without what I'm going to show you in the next couple of talks, really we can all advance together to become the limb salvagers or limb savers like we're supposed to be. So I'm showing you here some of the work that we did and we continue to do. By the way, I never stopped practicing the way I've been practicing throughout this entire process. So using procedural ultrasound to cross lesions that already been tried to cross before and failed, either by us, one of my colleagues, or friends. It doesn't mean that they're not really skilled, it's just they didn't use ultrasound at the time, use fluoroscopy. So because fluoroscopy shows you exactly the type of lesion that you see. And so here when you look at this lesion and you see this black component of it, what do you think of it? Easy to cross, not difficult? That is what you don't want to see. That is elasticalcinosis, the lesion that is very difficult to cross and requires some patience. And I'll show you, this is a very high gram tip wire, and you notice how the lesion is not respecting it at all. So before you get to that point, you have to make a decision. You have to go antegrade, retrograde, you have to go up and over. Well, whichever you decide to do, look at your access site to lower your complication rates, evaluate the confirmal artery, the bifurcation, and make a decision, can I go antegrade or not? And if you can go antegrade, decide where you're going to enter. Is it in the confirmal artery or the proximal SFA? If the proximal SFA is 6 millimeter or larger, there's a good data to support it if you do it very proximally, or the confirmal artery. And to do short access and long access, if you try it a few times, by the 10th time you do it, you start to get the hang of it. It's not really that difficult. Now you decided you're going to go antegrade, for instance. Get your exit strategy before you get in. Look at the tibial arteries. You use a 17 megahertz probe, and you look at the posterior tibial artery and anterior tibial artery and decide which one of the two would be your friend at the time of need in case you couldn't cross the lesion that you're going to cross. So you pick your target lesion distally, and then in this case here, I'm showing you the posterior tibial artery, and when you compress it slightly, you compress the veins. And this artery is a good conduit if you need it in this case. So now you have an entry component, you try to cross, and if that fails, then you have a sort of bailout strategy, retrograde access. And this is the anterior tibial. All right, these are the steps that you use. And actually, they're 9 quick steps. And you put the 17 megahertz probe, use the back end of the needle, you compress it, and you can see under ultrasound an indentation. That vector needs to be in the middle of the indentation. If you use it every time the same way, you will go into the artery basically in the first 60 seconds or less. And I'll show you the prime data registry that we followed this protocol to see how many tries it takes to get into the artery and also how much time. So this is a real-time tibial access part of the prime registry that we published, and it took that much time to get in. But that's after doing probably 100 or 2 of these. And then you will do the same after you do 10 or 20 of these. And if you don't try it, you won't get this good at it. And when you get good at it, you can save a limb a lot quicker. You can cross a lesion CTO within half an hour instead of spending 2 hours at it by getting this quick access. And the prime registry is published, so you can take a look at it if you're interested. This is really nice to show you. When artery is occluded for a long period of time, and there's no antegrowth flow in it, and collaterals are poor, and you still need the conduit, this artery is going to be constricted. And if it's constricted, and try to get it without ultrasound, it's a little bit complex. And if you hit it and it gets spastic, it's a lot more complex. Then if you use this technique we just talked about, look how small this artery is, but you can still get in it. And in the prime registry, we found that you can get into these arteries within less than 60 seconds. And the amount of time to try to get in, the average time is 1.2. This is important here. Not every artery is going to be pretty and easy to see. So you're going to have this patient with edema, patient with medial calcification, the intimal calcification is your biggest enemy, where you can't see the wire very well as you advance in it. So what is the trick? Use basic physics, right? You just rotate the wire back and forth, and you create reverberation. Reverberation is a lot more visible under ultrasound than flat. So this here, notice this 14,000 wire. When you do reverberation on it, it looks like an 035 catheter. So you can see it, and you maneuver it through the lesion. As you can see here, this is going through a CTO, and you can follow it exactly, and you take it where you want it to go, and then you just keep going. Now, to be honest with you, without this, I can't do the things that I've been doing, and I give credit to technology and embracing technology to advance our career. So now that you cross the CTO, you can confirm further by reverberating the water distally. So talking about something and saying, okay, we can do this and that, it's great. So we raised about $5 million, nonprofit organization. We did the PRIME registry, which is a multi-center registry. We wanted to see, well, if we take this and put it somewhere else in other hands, would we get the same results or we don't? And actually, to our surprise, we're very happy to say that the results were the same across the board. When you look at the number of attempts, it was average about 1.3, give or take, to get into the target artery. The time to access was, look at the numbers, less than 60 seconds the majority of the times, and there's as low as 20 seconds or so. And then the success rate is really the impressive part. I mean, it ranged from 99.4% in the common femoral artery to 70 to 80% in complex tibial arteries. These are not, by the way, straightforward tibial arteries, right? These are disease arteries, constrained. So I just want to give you some hope that there's a significant amount that you can do to your patients today if you apply this kind of data. This is not an opinion, this is data, and this is a large data set. And this is to kind of summarize it all together, looking at the mean number of attempts, mean time to access, and the access success rate. I mean, how often can you say, I'm going to be successful 99% of the time when I'm getting integrated common femoral artery access in the first attempt or 1.2 attempts, and do it in less than 60 seconds? That's phenomenal for the patient, right? There's no multiple sticks, there's no OA fistulas. The complication rate was significantly lower, it's unbelievable. And the same thing happens with posterior tibial, anterior tibial. And now that you have this kind of, armamentum with you, that you can empower yourself with it, and data to support it, why not go ahead and do it and embrace it? This is a beautiful slide. You can look up the article and read it, but look at the zeros that you see here. The complication rate was low, the success rate was high, the success rate across the complex CTO was high. So why not embrace something that is available to you in the corner of the lab for all of us, including myself? It took me years before I pulled the ultrasound from the corner of the lab and make it part of our practice at a day-to-day basis. So I want to show you a real case, a real world, that we all go through something like this, that we tried to open it didn't work. And this is a limb salvage case. So actually, success has to be the only option that we have for this patient. Otherwise, the alternative is not good. And this is CKD 3 patients with diabetes. So you know the arteries are not going to be pretty. And let's see what we can do in this case. We'll go through it together. The first thing I want to show you is negative remodeling. Negative remodeling is one of those silent entities that are the biggest challenge for us to cross the tibial CTO. When you learn to recognize it both on angiogram and ultrasound, that is actually half your success right there. So when you see something like this fractured vessel, that's called negative remodeling with a fracture, and you can then define the media, the intima, the medial calcium, intimal calcium, and the elastocalcinosis, elastofibrosis. When you see all of this together and you can actually differentiate it, and it won't take you long, just maybe 10, 15 times of doing it, then the decision to where to go and how to go, what to use, becomes so much easier. There's so much more wires today and catheters that can help you do this so easily that you can cross with no problems. This is obviously we crossed this, and before we're crossing, if you notice, the artery wasn't moving at all, right? It was just constricted. When you cross it and treat it, it starts to contract. Without contraction, pulse pressure, really you haven't done much for that patient. It didn't help them that much. So the external vascular ultrasound has no pulsation prior to crossing, showed pulsation after crossing, but also, most importantly, helped us cross a lesion that was attempted before and it failed. Now, if we had failed, the patient was going to go for an amputation. And you all know the data on amputation. If he gets an amputation, 18 months later, the chance of secondary amputation is significantly high, and the 4-year mortality rate is close to 80%. I mean, condemning a patient to death by not crossing a lesion should not be our priority, right? It should be the opposite. And comparing, CLI or CLTI to cancer, it was shown that CLTI is worse than 24 different cancers combined. So that's a serious disease. So this is here after crossing what I just showed you earlier, a seriously condensed high plaque burden vessel. I know there's a significant negative comments about atherectomy out there. I really don't care about that. There's an opinion versus what you're looking at right here. And there's a nice paper that was published recently showing the value of atherectomy, especially in tibial disease. Without debulking the lumen, you really can't get this kind of flow in the vessel. I want to show you this part. This is where the area where I showed you negative remodeling. Try to cross it from above with all the skills that we've had as a team. You can see the tip of the wire will get stuck in elastical stenosis. It's just like tar before it gets completely hard. You get stuck in it, you can't get it out. And if you keep looking here, I mean, how much can you keep doing that before you perforate or doing such thing? So you kind of like say, okay, I can't cross the integrate, I'm going to perforate. You get the hockey stick, you get a distal axis, and you come from below. Now, the best thing to do is when you come from below, you bring the catheter up and actually you rotate it under ultrasound, and you can see while you're rotating, you break this connection between the integrated wire and retrograde catheter, and now you put them both in the same lumen. Now you can just do flossing technique, which is really the best methodology we ever have. And this is going to show you here the flossing. Once you floss, the rest is very easy. And then CTO, the catheter is in the distal component here. CTOs and tibial arteries are not a single CTO. So when you cross one, you're not done. You cross one about 10, 20 millimeter long, then you have a 40 millimeter of no CTO. The next thing you know is another CTO is waiting for you. And you keep doing it until you cross them all. And every time you see the wire buckle, and this is like 60 gram tip wire, you see it buckle like this, think about an alternative method to come from below with the same catheter that you have, and you just rotate the catheter from below, break the elastical stenosis, and here you go. You enter both of them together. And when you get them into a flossing component, make sure that that's actually in a true lumen. It's not subintimal. And then if it is subintimal, what do? You just pull the catheter back, you rotate it, and you get back in a true lumen. And you can only do that by doing it from antegrade, retrograde, and by looking at it directly by ultrasound. And this is here to confirm, before we do anything else more aggressive to the vessel, debulking it, we kind of enhancing the image just to see that the wire and the catheter are properly flossed. We externalize antegrade, retrograde, and before anything else, we take a picture to see where do the vessels actually have just abrupt occlusion. You see the tip toward the great toe and the second third. These arteries are completely obliterated, right? So who can tell me quickly why are they obliterated? You got a Diet Coke if you can guess. Why does an artery get obliterated? Because of what? Gangrene, right? Gangrene is a primary cause of obliteration because it's transmural, trans tissue, complete occlusion. So if you have this image here, this is a high perfusion pressure image, so you know you're going to achieve a great result for this patient. It's worth using the ultrasound to get to this point, and this limb was salvaged, and actually this was done a few years ago, and the patient's still walking around in the same foot. Thank you guys for your time. Ladies and gentlemen.
Thank you.